Okay, so the last section of this very, very, very long lecture is about shock. And we're going to talk about what shock is and the different causes. Shock is circulatory failure. It means that the circulatory system is not able to perfuse end organ systems adequately. Okay, that's what we're looking at. For some reason, we're not perfusing organs and tissues adequately. So the pathophysiology actually depends on the cause, and we're going to talk about different types of shock in a bit. But what does shock look like? Low blood pressure. If it's possible for them to elevate their heart rate, they will do that before the blood pressure falls. Okay. Sometimes shock is because of a low heart rate, but if it's possible for them to elevate their heart rate, we're going to see an elevated heart rate. Low blood pressure, thirst, pale, cold, clammy skin, poor cap refill. GFR and urine output decrease, and that progresses to anuria. If a patient is not making urine, their kidneys are not perfusing adequately. The patient may be anxious, apprehensive, irritable. They may feel like something is wrong. They may not be able to tell you specifically what it is, just feels like something's wrong. That progresses to confusion, somnolence, and then coma. Tachypnea progresses to periodic breathing or apnea. So at first they're breathing faster, but eventually they start to, they'll slow down and stop breathing. And they develop metabolic acidosis because of the lactic acid produced by those damaged tissues. Complications: if we don't perfuse the brain, the central nervous system, we can have cerebral edema, stroke. Okay. If we don't perfuse the kidneys, we can have renal ischemia. Also, if the blood flow is low enough, we can have renal vein blood clots, renal vein thrombosis. So renal ischemia means eventual renal failure, right? If we don't perfuse the lungs, we can have decreased surfactant and end up with ARDS. We're going to talk about ARDS in the respiratory lecture, acute respiratory distress syndrome. If we don't perfuse the GI tract, we get ischemia and necrosis of the spleen, the liver, the intestinal lining, intestinal mucous membrane. Metabolic complications of shock can be hypoglycemia, hypocalcemia, electrolyte disturbances. So what's happening is the damaged tissues start, we have, may have potassium release. We're going to have alterations in all those electrolytes, and we have increased metabolic demand. So we use up glucose faster. Shock diagnosis is by history and exam. The severity is determined by measuring vital signs, and that includes central venous pressure. So if a patient is suspected to be in shock, they probably are going to get some sort of CBP monitoring if possible. There are stages. Compensated shock means that they're able to maintain vital organ function. So in the beginning, they're not perfusing well, but they focus on perfusing vital organs. Blood flow can be normal or increased, but it's uneven and poorly distributed. So they may have normal blood pressure, elevated pulse, pale, thirsty, decreased urinary output. Okay. Uncompensated means they are no longer able to adequately perfuse their vital organs. They get confused, tachypnic, oliguric, cool, pale extremities. So they look sicker. Irreversible shock means that damage to the vital organs is not survivable, even if we can reestablish normal vital signs and cardiovascular function. So medically, the patient may be ventilated. They may need airway assistance. They may need artificial ventilation, and they may need pulmonary edema managed. So if it's cardiogenic shock in particular, they may have pulmonary edema. They need fluids to restore blood volume, and vital signs and urinary output are monitored really closely. Heart function has to be increased. They may have meds to increase the contractility, meds to maintain arterial pressure, and meds to reverse the acidosis, and then treat the cause. So airway, breathing, circulation, fix what's wrong. Shock is usually shock is a circulation problem, but it can affect airway and breathing. We got to take care of those. fix the circulation, and then treat the cause. Nursing care, our priority is tissue oxygenation. A priority is tissue oxygenation. They may be on oxygen. We may assist with intubation and ventilator support. We would be establishing IV access. We need more than one IV. Fluids, there are guidelines for how quickly we administer fluids in shock now. We may give meds as indicated. They probably need an indwelling catheter to keep up with that INO because we need to be really, really monitoring their output closely. Baseline assessment, we get vital signs, weight, and ABGs. We want to position that patient flat with legs elevated, so we maximize the blood return from the legs, so we get all the blood they've got perfusing their vital organs. They're on a cardiac monitor, hourly INO, vital signs every 15 minutes. Invasive monitoring is used to titrate fluid. That line is going to be placed by the provider, but it's managed by ICU nurses. Update the family. If someone can stay with the family, that can help with their anxiety, and then they need to be allowed in as soon as feasible. So we're going to look really quickly. I want to look at MAP. So I'm going to pause. We're going to come back and look at MAP. Okay, so one of the things we look at to determine if someone is getting adequate perfusion is mean arterial pressure, or MAP. And we don't calculate this on every patient, but if a patient is in shock for whatever reason, we want to maintain their mean arterial pressure above 60. Okay, 70 to 110 for adults, 70 to 100 is considered normal for adults. Above 60 is considered adequate for adults. Now, for children, that appropriate number, that normal number, is going to vary. It's going to change by age and size. So when you're looking at adults, we're thinking over 60, but when you're looking at, say, a 3-year-old, you need to look up, what should that 3-year-old's MAP be, okay? So I'm going to show you how to calculate MAP. And then we're going to move on and talk about the causes and types of shock. Let me find, here it is. Okay, so here's your formula. 2 times the systolic blood pressure plus the diastolic blood pressure, and you divide that by 3. So if our systolic blood pressure is 120, that would be 240. Plus diastolic pressure 70, and we're going to divide that by 3. Okay, so 240 plus, let's make it 60 to make it easier. 120 over 60. So 240 plus 160 equals 300. So divided by 3, the MAP is 100. Okay. So I wanted you to see how to do that. It's a really quick, easy calculation that you can do in your head when you remember how to do that. Okay. So mean arterial pressure is something that we monitor to see, is that patient actually being adequately perfused? Now, what are the different causes and types of shock? Because that's going to determine the treatment after the initial, we've got to get this patient perfusing. Okay, so the initial focus of medical management is ventilation perfusion. After that, they are trying to figure out what's the cause and get it fixed. So shock can be hypovolemic. That can be because of reduced blood volume. Okay, or that's reduced blood volume. Now, how do we lose blood volume? Well, we may lose blood volume by losing blood. Okay, we may lose blood volume by losing plasma or extracellular fluid. So someone would have a hypovolemic shock because of blood loss, or because of, say, severe prolonged vomiting diarrhea. Okay, either way, they don't have enough fluid in their bodies. They're not getting enough venous return to the heart. Blood pressure drops, pulse goes up to try to compensate. The arterioles and veins constrict. So if they're trying to maintain, if we don't have enough blood flow to perfuse everything, we try to maintain and perfuse just the critical systems. So what that means is that patient may look pale. They maybe have irregular color. They may have some modeling, okay, because they're vasoconstricting to try to perfuse the important systems. Decreased tissue perfusion. If they can't perfuse all of the critical systems, and they start perfusing brain and heart first. Anaerobic metabolism, because those tissues that can't be perfused have to get energy somehow, and they're losing oxygen. So anaerobic metabolism produces lactic acid. So their lungs try to compensate by blowing off CO2. Remember metabolic acidosis, they can develop Kussmaul respirations. So at first we're going to see our blood pressure might be okay, but heart rate and respiratory rate go up and they look pale, cool, mottled. Okay. If they can't keep that up, the arterials get tired and dilate, the venules do not. So that means they start to have pooling in the capillary and venule beds, and then that further depletes the blood volume. Okay. So the fix for this is replacing the volume. Distributive shock means they've got enough blood, but they can't distribute it correctly. This may be, there's different causes for this. This may be anaphylactic. Anaphylactic shock, a person is exposed to an allergen. Histamine and other chemicals are produced and cause vasodilation, bronchoconstriction, and increased capillary permeability. Okay, so when we vasodilate everything all over our whole body, we can't maintain enough blood pressure to perfuse vital organs. Okay, onset can occur in seconds to minutes. The prodrome, before they vasodilate and pass out, they may feel uneasy, restless, anxious, headache, dizziness, paresthesias, disorientation. They may also get flushed and itchy because of the histamine. They may have angioedema, swelling around the mouth and throat. They may have bronchoconstriction and go into respiratory failure at the same time that they're vasodilating and not perfusing anything. They can develop pulmonary edema and hemorrhage. Laryngeal edema causes airway obstruction. Vasodilation causes cardiovascular collapse. The treatment: treat the shock, remove the cause, antihistamines, epinephrine. For prevention, we want to help this patient identify and avoid their allergens, and they should carry an EpiPen. We need to teach anyone with anaphylaxis that an EpiPen is just to get you to the ER. It is not a replacement for an ER trip. Epinephrine will bronchodilate and vasoconstrict enough to perfuse the important stuff to get you to the hospital. Okay, but they still need to be treated in ER. Septic shock is when infection triggers inflammation. SIRS is systemic inflammatory response syndrome. Sepsis is a systemic response to a systemic infection. Okay, so they have an infection, maybe they have an infected ulcer. They don't get it treated. That infection gets into the bloodstream, their entire body becomes infected, and then they have an inflammatory response to that. Remember, we have an inflammatory response to infection. Those chemical mediators cause vasodilation and increase capillary permeability. So the capillaries get leaky, so the blood they have is not appropriately distributed. What does this look like early on? This patient may have chills, fever, and vasodilation. They may be flushed. When they get to the decompensated stage, their skin is cool, their temperature may be normal or even low. Their temperature may be low. Their pulses and blood pressure may be normal. Their output decreases. They have decreased level of consciousness. Okay, so they are cooling down. Cold sepsis, they're hypothermic, they have cold extremities, weak pulses, hypotension, oliguria, or anuria. Okay, cold sepsis, it's hard to bring them back. If they still have fever, your chances are better. Treatment, treat the shock first. So massive fluid infusion is the first line. Give them something to pump so that we can maintain perfusion, and antibiotics. There's a risk with sepsis of ARDS and DIC. ARDS is acute respiratory distress syndrome. Again, we're going to talk about that in respiratory. DIC is disseminated intravascular coagulation, when we set off all of the blood clotting factors at once in the body, and they run out of clotting factors. Early identification of sepsis is the key to survival, so we need to have a high index of suspicion. One of the things we look at to determine if someone may be septic is lactic acid. Lactic acidosis is a sign that they're using anaerobic methods to get energy for body tissues. So lactic acidosis. Neurogenic shock happens after a spinal cord injury because of effects on the autonomic nervous system. Remember that the autonomic nervous system, when you stand up, vasoconstricts to keep the blood up in the top of your body. That is damaged with the spinal cord injury, and they may just have massive vasodilation below the level of the injury. Because of that vasodilation, their blood pools in the lower extremities. Again, treat the shock. And then this is usually an acute thing after a spinal cord injury, so it gets better. Okay, so treat the shock. Toxic shock syndrome is caused by toxins produced by staph bacteria. We think of it as associated with tampon use. That's one of the most common causes, but it can actually happen because of other staph infections. The toxins cause SIRS, so remember septic shock. Okay, so all the same things happen. Treatment, again, treat the shock and then antibiotics. Cardiogenic shock is when there's adequate blood volume, but the heart is unable to pump effectively. And again, treat the shock and then work to improve cardiac function. So what is treatment for shock? Okay, if there's decreased volume or massive vasodilation, they're going to give large amounts of IV fluids to maintain some blood volume. For cardiogenic shock, you don't want to do fluid overload, so they're more cautious with fluids. They also can give meds. These are titrated IV drips to vasoconstrict. Okay, they give pressors that vasoconstrict the peripheral vessels, and that helps maintain more perfusion to the vital organs. So pressors may help maintain blood pressure so they get adequate perfusion. I'm not going to ask you to learn specific pressures this semester. You will get into that next semester, but you need to know, we're running into this even on the med-surg floor, that some meds, the intention is to maintain adequate blood pressure to perfuse while the cause of shock is being addressed. Okay, this was very long and it was a lot. Spend time with it so that you understand it well.